Well, ladies and gentlemen, please welcome to the Wound Care Knowledge Thursday edition of this blog. For today, here is the question. You are a clinician treating a patient with sickle cell anemia. Which of the following can signal that your patient may ulcerate? Again, you are a clinician treating a patient with sickle cell anemia. Which of the following can signal that your patient may ulcerate? Letter A, hemoglobin of A1C, hemoglobin A1C of 9. Letter B, edema. Letter C, high fever. Letter D, resolution of pain in the leg. And letter E, ambulatory status with walker. The answer is edema. So hemoglobin A1C is not usually associated with sickle cell disease, and the people with sickle cell disease usually come with high fever of unknown origin, and they usually come in a lot of pain, especially when they are on crisis. Now, the restoration of their ambulatory status is actually a good thing for them. Once the pain and the fever and whatnot goes down, their ambulatory status is uh, actually uh, restored. So among the choices, only edema. If you look at the edema wound cycle, if there's edema, there's wound. Some wound causes edema. So it just initiate the cascade of event leading to an ulceration of the skin. So, so with regard to the ulcer pathogenesis in sickle cell disease, the abnormal hemoglobin molecule in the red blood cell in a patient with sickle cell does not affect the amount of oxygen the red blood cell can carry. After the red blood cell in its hemoglobin gives up the oxygen to the tissues, the abnormal hemoglobin causes the red blood cell to distort and become rigid. This results in the cell becoming deformed into a sickle cell shape. When the red blood cells are reoxygenated, when the red blood cell is reoxygenated, the cell resumes its normal shape. Unfortunately, while the cells are in a sickle shape, they tend to increase blood viscosity and become sticky. This causes slowing of the blood flow in the small vessels and subsequently clotting of the vessels. This results in ischemia of tissues in organs. Over time, the patient suffers repeated episodes of pain, tissue damage, and eventually organ failure. Many times the cells become damaged while they are in a sickle shape and have a shortened lifespan. Because these cells are removed from the circulation faster than normal, anemia results. Although the exact cause of sickle cell ulcers is not clear, they have been associated with trauma, infection, severe anemia, and warm temperatures, and are most likely to occur in the malleolar area of the lower extremities. It has been suggested that the sickle cells cause chronic damage to the microcirculation in the skin at the ankle. This damage includes injury to the capillary walls, thickening of the intima lining of the capillary, and increase in permeability of the vessel wall. This would allow macromolecules to escape into the tissues. These changes result in the skin having a reduced blood supply, being more susceptible to minor trauma and being less able to heal. As a result, these areas of involvement are more likely to be the site of a skin breakdown in ulceration. It has also been suggested that a reduction in the amount of the smooth muscle relaxant Microcirculation can result in unrestrained vasoconstriction of the small vessels, ischemia of the skin, and skin necrosis. I hope you learned something today, and if you did, please don't forget to share, like, and subscribe so that I will see you again. Thank you and take care.